Assalamualaikum doctors. In this video I am discussing the management discussion portion of the febrile neutropenia. First of all, what is the definition of febrile neutropenia? That is temperature more than or equal 30 degrees Celsius at any time and neutrophil less than or equal 0.5 into 10 to the power 9 per liter. So definition is temperature more than 38 degrees Celsius and the neutrophil count is less than or equal 0.5 into 10 to the power 9 per liter. Now what investigation we do? Full blood count, blood grouping and SAVE. Blood culture both lumens and portaket, urine electrolyte, creatinine, lactate, blood gas and liver function test. Inflammatory markers are CRP, ASR and ferritin. If septic, also do a coagulation screen, PT, PTTT, D-dimer and fibrinogen. Then urine urinalysis in all children, stool sample, stool culture, diarrhea. Imaging are chest X-ray if respiratory signs, increased respiratory rate and auscultatory signs. Viral screening are respiratory viral screening if chorizal and or cough, nasal or throat. Okay, so investigation I am telling what we do. Full blood count, blood grouping and SAVE. Blood culture both the lumens and portaket. Urine electrolyte, creatinine, lactate, blood gas and liver function test. Inflammatory markers are CRP, ASR and ferritin. If septic, also do a coagulation screen. PT, PTTD, D-dimer and fibrinogen. And urine urinalysis in all children. Stool sample, stool culture if diarrhea present. Then imaging we are doing chest X-ray if respiratory signs, increased respiratory rate and auscultatory signs. Viral screening are respiratory viral screen if chorizal and or cough, nasal or throat. Management will isolate the child, airway, breathing, circulations and dehydration status. If needed, start resuscitation. If the child in shock, 20 ml per kg normal saline we are giving. Monitor the urine output. Admit to the PICU after discussion with the consultant. Cubicle. If in pain, give analgesics. Do not wait for result. Administer antibiotic. Empirical. First empirical. Then according to culture sensitivity, door to needle time must be within 1 hour. Okay. Follow individual trust antibiotic policy or individual patient plan if resistant organisms. So management I am telling, first isolate the child, separate cubicle we keep. Airway, breathing, circulation, dehydration status we search, and the shock child is in, if shock, resuscitation done, and shock 20 ml per kg we are normal saline giving running. Monitor the urine output. Admit to the PICU after discussion with the consultant. If in pain we give analgesic. Do not wait for the result. Administer antibiotics. Empirical, then according to culture sensitivity, door to needle time must be within 1 hour. Follow individual trust antibiotic policy or individual patient plan in if resistant organisms. So this is the management. Antibiotic we give vancomycin, pre-dose vancomycin level and low risk when to discharge if clinically well, febrile more than or equal 24 hour and there is no growth in blood culture after 48 hour. Then stop antibiotic, no need for routine inpatient observation after stopping antibiotic. So when febrile more than or equal 24 hour, clinically well and no growth in the blood culture after 48 hour, then we give the discharge of the patient. Antibiotic are commence piperacillin with tazobactam. If penicillin allergy, then receiving IV methotrexate or previous tazocine resistant gram-negative infection, use meropenem. Stop prophylactic antibiotic apart from cotrimoxazole. Okay, so the antibiotics are mainly commence piperacillin or tazobactam. If resistant to tazocine, then we give the meropenem also we can give, and vancomycin we can add. So this is all about the management portions of febrile neutropenia. Thank you.